So let's kickstart with some questions. I normally want, you said you use, the recommendation is to use ulnar artery instead of radial artery. Why is that?
Ulnar artery if you're using the other device, the radio frequency device. But if you're using the ellipsis device, almost you cannot use any other artery but the proximal radial artery. And that's because the proximal radial artery lies almost alongside the deep perforating vein. And one other criteria that has to be fulfilled is that the distance between the deep perforating vein and the proximal radial artery has to be within 1 or 2 millimeters. If it is more than that, then you cannot use that patient cannot use that ellipsis device. But the Everlink device, they have used predominantly only the ulnar artery for that.
Is that some sort of, is there a reason to use an ulnar artery there? Because
I think it's the anatomy. It does communicate straight. And I disclaimer, we do not use the Everlink device. But what has been reported is that it is because of the anatomy and the size of the ulnar artery, which usually tends to be bigger. And also the ulnar vein communicate directly with the outflow brachial veins and the deep communicating veins. Again, in those patients as well, it is important that the deep perforating vein has to be patent, because the flow from the ulnar veins, which normally drains out into the brachial veins, has to come into the superficial veins through a patent deep communicating branch. So if the deep communicating branch is not functional, then that may not be an option for that patient as well.
Okay. Tarun,
Yes, sir.
you have a question to Dr. Sachdeva? Because this is something new and we've been trying to do it.
I think for last 2 to 3 years, we are just waiting for this device to come in India, and we are just eagerly waiting.
So, yeah, I think I've had the discussion with the device makers, and they've been trying to garner more data on the outcomes, so that paper that I was telling you about, the 2-year patency that was just published about a month and a half ago. So their goal is to have the device fairly established with outcomes, and then they're going to go out and market it outside of the United States territory.
Yeah, could be because this is something, every Charing Cross I go and sort of train myself and attend those workshops for 2.5.
Yes, absolutely, yeah.
But we've been waiting for this and eagerly waiting, and we hope getting late, maybe some Indian device or industry actually gets the idea and starts making something similar.
Absolutely.
The advantage is, the surgeons always have an advantage, they can still do something, and we as interventional we have some handicaps apart from having some strong points, but that is somewhere we actually, the only other way which we think is like, if you're going to join Tarun and learn how to make fistula, we were making it to make it.
But the good thing is, if these devices come in India, we have so many, I would say, patients who will be benefited, because though we have a poor population, but we do have a very rich population as well. And, I would say the numbers will be so high. So probably the company, because the volume is significantly higher, then the price can also come down, because if the business goes up in a country like ours.
Right, and the technology is very simple. The thermal ablation technology, and I'm sure they have a patent for a period of time. And once that runs out, I'm sure there will be other competing devices in the market as well. So I think the future does look really promising. It does not take but about 20 minutes to create a fistula, and so that's the beauty of it. In 20 minutes, you are in and out, and you have a working fistula. The person's come back in 4-6 weeks. We do an ultrasound, we mark the fistula for a way to cannulate, and the patients are good to go. So the outcomes are what will really drive the growth in this particular axis.
No, I fully agree, because I feel, the more minimally invasive you get, that's the way forward for every procedure.
Right. Yeah. Absolutely. I had a question about the Supera that you're using across
Yeah,
the radiocephalics.
yeah.
No, we've used some of those as well, and it essentially just changes the anastomosis from being a side to end anastomosis, a side artery to an end anastomosis, to an
Mhm.
end-to-end anastomosis. And the key part, I just wanted to make sure that I point that out, is that you have to make sure that the ulnar artery is patent when we do that, because you're taking away the radial supply to distal. And in most, almost, I would say 8 out of 10 distal radiocephalic fistulas that you see, the distal radial artery is usually flowing retrograde. So there is always a steal from the ulnar that is feeding into the radial artery as well. But despite that, the flow coming from the radial artery does enhance when you change that anatomy of that configuration. Um, no, is Viaband stent available? Gore Viabands, are they
Viaband,
Uh,
I
available?
think last
Not
few years
right
have
now.
been withdrawn. So.
Mhm.
So, that was a concern with us also when we started using the Supera because, the smallest size is 4.5. And as you will know that, Indians don't have a radial artery, which is bigger than, if it's very big artery is also 3. So,
No, I see a 2.5 artery here as well.
so, we restrict if the artery is around 2.5 to 3, then only we use Supera in these patients. And
Right.
we do have this concern because some people they have advocated Supera in the popliteal aneurysm because it works as a flow diverter. So if it works as a flow diverter, then definitely what you're saying is it will cause a significant steal to the distal radial artery because you are diverting the flow back into the cephalic. And but fortunately we have not come across any, and usually patients who have these radiocephalic fistula, so usually they have a patent ulnar, but definitely that's a very important point to rule out that. And on certain occasions we have used even for brachiocephalic also, but fortunately we have been following up these patients so they don't have a significant, I would say, flow limitation beyond the anastomosis from the brachial artery going to the distal radial and
That's
ulnar.
true. Now, there are some brachiocephalics. Actually, I've seen as much as one. About there's no true idea of how often do we see this anomaly, but there is an accessory brachial artery in a majority of the patients. And unless you do an arteriogram through the subclavian artery and then study the anatomy, so perhaps some of those patients that you have done that, maybe they could be an accessory brachial artery as well.
So that anomaly, usually either it's a high bifurcation or something similar to, like, we call it a profunda femoris for the femoral. It's like a profunda
Right.
brachia in mid-arm. So
Right.
that usually suffices if you have that compromised flow.
Perfect.
I believe both of you do most of your interventions, on these veins, ultrasound guidance. We prefer to do more of them in the cath lab and through an arterial injection always. So,
Yeah. So our most of the interventions are also in the cath lab, but sometimes you do have limitation if you have a patient who has been on a regular follow-up, and we know that we are dealing with a disease which is only restricted to either forearm or arm, and rest of the veins are very well screened on previous occasions, and he's not suffering from any central venous stenosis. So those patients can easily be carried out on a duplex. And but otherwise definitely some primary case where you are not sure of the central veins and you don't know what's happening beyond, I would say, shoulder. In those cases definitely a fluoroscopy will definitely guide us and give us a better information.
even
Okay,
for
there are a
physical
couple of
intervention
questions.
also, we actually, tend to do an arterial shoot, and just because what Dr. Sadhva is saying, we have a clear anatomical delineation of the arteries.
Yeah.
And we know in case we are going to sacrifice something, what is the jeopardy we are going to create. And that's our
Absolutely.
thing, but more and more now we have gone from arterial, we are going distal radial, and that works out quite well in many of these in the forum.
There are a couple of questions on the chat room. I'm just going to read them out. How many procedures have to be performed to be competent? I think you need at least 2 or 4 supervised procedures with a mentor to make sure that you really understand the anatomy. Once you have a good control over the ultrasound skills, and make sure that you can identify those patients. There's a lot of procedure training that you have to do to make sure that we can find the right patients during the procedure. You have to have the right amount of skill sets, and then post procedure there has to be some amount of training for the dialysis techs that are going to be accessing the fissulas, because these fissulas, normally we're so used to knowing where the anastomosis is using the scar. These guys don't have any scar, so there has to be some amount of training imparted to them as well. And then there's a second question: which one is better, ellipsis or Everlink? I think it's a question of preference. We do not use Everlink. Ellipsis device has it's a one-step procedure. You can create the fistula using an ultrasound itself, and there is no arterial puncture involved. So you can argue that because you're using only venous puncture to create the fistula, you may have a better option. And also with ellipsis, even if that fistula fails, it does not preclude the use of or creation of a distal radial artery fistula, because you've not compromised the ulnar artery. So you can potentially go and create a distal radial artery fistula after you've done an ellipsis device. With an Everlink device, that may be if the ulnar artery is thrombosed or it doesn't work, then that may not be an option for a distal radial artery fistula in that patient.
Okay, if there is no other question, let us close this. I'm not seeing Dr. K.N. Singh and Dr. Gaurav Sagar, but I believe they are, they are on the panel. I can't see them on the camera. I've been told they are there. Is Dr. Singh there?
No, sir.
Because we did this session in association with Avatar, and Dr. K.N. Singh is the president of the Delhi Nephrology Society, and Gaurav is the secretary of Avatar. Now we'll end here, and thank you very much. Thank you, Dr. Bharat. Thank you, Tarun. Woolen has
pleasure.
And we apologize for being a little late because that program extended, and it was a last minute confirmation and a last minute infusion, so we had to be extending it a little beyond that. And Woolen was supposed to speak in the previous session to that. We had to adjust. Thank you all very much, and we are going to be, archiving this, and we'll probably be writing to you for your presentations. It's there for you and training for further society members. Thank you all very much. We'll welcome you for the next step, maybe next step physically, if it is possible and things are better. Otherwise, let's see how what is the new normal for subsequent years.
Thank you again, and I wish everybody stays safe, and hopefully we'll be over with this crisis soon.
Definitely. Yeah. And nice seeing you, Dr. Bharat. Nice meeting you.
Good seeing you too, sir.
Yeah. Okay, bye-bye. Okay, good night, sir.
Good night. So you are staying at Shreveport, or you are working at Shreveport?
No, I am in Shreveport. The Ochsner has a new partnership with LSU Health Center. So LSU University and Ochsner have combined hands. And so this is a new partnership that has been there for about a year and a half now. So now we go bringing up some new changes. There is a lot of investment going into the LSU system. So I think this is a partnership that should benefit everybody. Ochsner really wanted to go have a good medical school. So with LSU, they have access to their first medical school in United States. So I think it's a good academic partnership for both.
Yeah, that's true. And I believe I used to be there in 1998, 99. That time, Ochsner, we used to go to Ochsner, to Shreveport to do some cases. They had some clinical tie-ups in some hospitals and a small clinic there. Right.
Now, I think in Ochsner, in terms of their growth, have had phenomenal growth in the last 10 years. I think they have about 35, 38 hospitals that they manage in Louisiana and around. They have a affiliation with a medical school in Australia as well. And LSU would be their first medical school affiliation in the United States.
That's great. Small work.
Good seeing you.
Thank you.
All right. Stay safe.
Thanks. you. Thanks.